Next we could have Gina, Luciano, come on down. Here she goes. Oh, she gets extra bonus points for dancing. Nicely done.
There's nothing like watching a pregnant woman dance to House of Pain. Thank you for having me here. I'm the director of the primary care program at Baystate. I'm thrilled to share our model of training with you. So by the time medical students graduate, only 2% want to become primary care docs. PCPs are for the most part less well compensated than subspecialists, so the debt-to-income ratio is quite unfavorable for students. Additionally, the prestige associated being with a PCP is less so than a subspecialist. Hospital rotations limit learning about chronic diseases because they're usually short, finite experiences. Traditionally, residents see a patient only once during a short elective, rather than following that patient over time and learning about the patient themselves, their disease, and the intricate relationship between the two. Finally, residents care for the most challenging patients in the most challenging environments. Resident clinics usually care for patients who are socioeconomically disadvantaged in low-resource settings. This is hard for even the most seasoned PCP and is really not a realistic experience of what a primary care career can be for many people. At Baystate Medical Center, we have a 716-bed hospital. We're a tertiary care center. We have 54 categorical residents, and we have up to 12 primary care residents at any given time. We were awarded a HRSA Affordable Care Act grant in 2011. We can have up to 4 residents per training year. We have 3 innovations that make our program very unique. 1, we have 2-week alternating block schedules. This means that our residents are never apart from their ambulatory patients for very long. 2, our primary care residents do not participate in any month-long hospital-based electives. Instead, all of their electives are year-long, calendar year-long, and they're ambulatory electives. They're all continuity electives. Finally, our residents participate in community projects outside of the hospitals where they're advocating for their patients. So if you look at the first 6 blocks, that's in the red, that's where our interns are participating in orientations and core rotations. This is simply to get them used to the hospital setting and culture. After that, starting in block 7, which is January of their intern year, they begin their 2-week experiences to maximize continuity. As you can see, there are no electives here, and almost every single block from here on out contains an ambulatory rotation. So if we blow up block 7 just so you can see what an ambulatory rotation actually looks like. This is a sample week in the life of a primary care resident. The first 2 weeks they were in the ER, the second 2 weeks they're in ambulatory. This particular intern is participating in 5 subspecialty electives: GI, geriatrics, nephrology, endocrine, and a private practice primary care second site. They're in highly functional outpatient practices. They have the same preceptor for the entire calendar year, and many of them have their own continuity patients that they're seeing in these clinics alongside their subspecialty preceptors. In addition to, I put the core electives up here, but in addition to that, we offer procedure clinics, women's health, a jail clinic. Pretty much anything that our residents want, we can make for them. We also have the traditional continuity clinics at our resident clinic. That's what you see all day on Friday and Tuesday evening. And in addition, we have a community project that this person is participating in on a Tuesday morning. The guidelines are vague for this purposefully. They need to be out in the community advocating for their patients. To give you an example, one of my residents has set up a nutrition curriculum for high school students at a nearby high school. Another one of my residents works at a survival center where he does health education for homeless patients, and he does administrative duties within that homeless shelter. So some outcomes. Our residents are extremely engaged in managing patients. They follow these patients over the year, they do home visits, they form relationships with them, but they also form relationships with subspecialty preceptors, and this is key. When a puzzling or challenging patient comes in, they don't automatically call a consult. They call their network of subspecialty preceptors. They text them, they call them, they talk with them the next time they see them. They have this network where they can discuss chronic disease and management. Not only are they learning about medicine, but they're helping their patients. Their patients aren't going for as many consults. They're participating in continuous dynamic healthcare. They don't just see the diagnosis. They see the diagnosis, the progression, the management. They build relationships with these patients in the subspecialty clinics. As I mentioned before, they're involved in advocacy through community projects. They understand where their patients come from. They understand their environments. And finally, this is my favorite thing, we have something called primary care jealousy. So many of our categorical residents are actually very jealous of our primary care residents. I've had 2 categorical residents switch into the primary care track. Both had surgical training before that. I've had 0 dropouts from the primary care track so far. So I just wanted to thank everyone, and any questions?
Just a very quick question. Oftentimes, reimbursement's an issue when people don't go for formal consults, and we kind of curbside a lot of specialties. We don't get formal kind of reimbursement from that. Have you found that to be an issue?
No, first of all, my subspecialty preceptors love these residents. They try very hard to convert them into whatever specialty they're doing. But also I think in terms of how accountable care, hopefully we'll get to accountable care at some point. I mean, it really will be, we should be curbsiding our specialists, I think, at some point. So no, we have not had that issue. I've never had any of the subspecialists talk about that.
Hi, thanks for the talk. So I wanted to ask a little about the very last thing you just said about people switching in and out.
Yep.
Because I was thinking, as you maybe know, even in med school, there might not be a lot of exposure to primary care. So at what stage do people commit to this track, and what kind of capacity do you have, or what kind of waves does it create when people do want to switch in, as it sounds like the case is?
Great question. So we have a separate match. So some people commit before they get to our program, obviously, and then we allow our residents to switch in anytime they're during their first year. It makes it a little harder after they've really gotten to their second year, just because setting up the continuity electives for them and them having the relationships with those subspecialty preceptors is a little more difficult. But we had 2 switch-ins in the past couple of years. One had completed her first year. She's actually going to be our ambulatory chief in a couple of years, and the other one, he just had 2 months of it and loved the experience of the other residents and said, "Hey, I'm primary care also. Is that okay?" So of course.
Thanks.
I love the example of being able to curbside more specialists, cut down on the referrals. That'd be a really interesting metric to track across the years and see how that evolves and compare to the control, which would be the non-innovative track.
Absolutely.
What formal metrics have you generated so far to really evaluate this program?
Great question. We've had our first graduated this past year. So we were looking at a few different things. One, I'd love to do a qualitative study to really see what is the difference between the primary care residents and the categorical residents in terms of how they think about chronic disease progression and management. We actually talked about exactly what you just said in terms of consults, but not just number of consults, quality of consults. What kinds of questions are they asking of their consultants? How appropriate are they in terms of whether they really should be going to subspecialists or whether primary care docs can handle them?